I have the dear pleasure to introduce Dr. Mitsuko Yamamoto. She's a friend of mine from Sanofi, and she's an incredible clinical researcher at the Sanofi Medical Institute. She's a very enthusiastic scientist with a professional experience in integrative therapies and clinical data analysis from patients with chronic and degenerative diseases. Also, she specializes in scientific dissemination and health wellness. And we have had a few projects with her, and I'm really excited to introduce her title here, Beyond Degeneration, Clinical, Serological, and Anthropometric Markers of Chronic Infection. Thanks, Mitzu.
Thank you, Leona, and good morning, everyone, and good evening from this side of the world. I just want to make a quick clarification because we're going to talk about these clinical, serological, and anthropometric markers of actually chronic tick-borne infections. Okay, so first, I have no conflict of interest to disclose, and I want to go through these learning objectives. First, symptom patterns can differentiate chronic tick-borne infections from non-infectious degenerative conditions. Also, serological testing reveals polymicrobial exposure in chronic infection patients. And at the end, to present a model that leverages clinical and biomedical data from Lyme patients to support predictive and personalized clinical decision-making. Okay, so we know that we've seen through these 2 days of this amazing conference that tick-borne infections are a growing global health concern. Practically, we can see tick-borne infections practically all over the world. And the thing is that we often think of tick-borne infections as acute illness, but the thing is that they can persist and they can become chronic, and they can show symptoms like fatigue, body pain, muscle pain, neurological issues that can mimic these non-infectious degenerative diseases. So this overlap challenge and complicates the diagnosis that leads into this delayed treatment or inconsistent treatment that will result in uncertain prognosis. At the very end, this will result in a negative impact of the quality of life of patients. So, in order to overcome these challenges, AI and machine learning can leverage real-world biomedical data to identify these hidden patterns and predict disease trends. Also, if we integrate AI and machine learning with medical expertise, we can offer potential better outcomes and also a better approach for managing the tick-borne diseases. So with this in mind, I want to go through this and share with you these results. So this study aims to compare the clinical, serological, and anthropometric profiles of patients enrolled in a chronic infectious programs versus patients with non-infectious chronic degenerative diseases. Also to identify symptom patterns and serological markers that may assist in the clinical differentiation of chronic infection etiologies and to analyze the prevalence and clinical relevance of antibody-mediated immune responses to tick-borne pathogens in patients with chronic symptomatology. For this, we built a database with retrospective biomedical information of patients who participated in an integrative medical program at Sanofi Medical Institute. We did a random selection of 692 patients from 2021 to 2024. Just a quick background for those who doesn't know Sanofi. This is a fully licensed hospital that combines conventional medicine with integrative therapies. We are located in Rosarito, Baja California, Mexico. And we offer medical programs mainly for patients suffering from chronic diseases. And all of our patients are seen through this multidisciplinary approach by a team composed by a treating physician, a nutritionist, a psychologist, a mind-body therapist, a chiropractor, a fitness instructor, and also a dentist. So this database was divided into two study groups, 392 patients that completed the chronic infections program, that I'm going to refer to it as the SIP group, and also 300 patients with chronic degenerative diseases that will be are namely the control group. For the SIP group, patients, of course, need to have chronic symptomatology, but they also need to have an antecedent of a tick-borne infection. I mean, they can have history of tick bite, history of erythema migrans. Maybe they do not meet all the CDC criteria of the two-tier test, but they can have a positive or a borderline test for Lyme, or even this evidence and a strong antecedent of living in a Lyme endemic area. For the control group, it corresponds to patients that enroll in any other integrative medical program with diagnosis of chronic diseases of non-infectious etiology. We register several variables in different categories. Of course, demographic information, the symptoms, the complete blood count, the blood chemistry, their body composition, and the tick-borne plus. This test was done only in the SIP group. And as you can see, those tests are fairly inexpensive, and we can have it right at hand as a general practitioner. So the symptoms, we record them as presence or absence of the following: fatigue, headache, myalgias, arthralgias, cognitive decline, fever, the prior use of antibiotics, the history of erythema migrans, psychological trauma or active psychological trauma, and history of COVID-19. For the complete blood count, all the leukocytes or white blood cells, absolute and percentage of neutrophils, lymphocytes, eosinophils, basophils, and monocytes. Also the red blood cells, hemoglobin, hematocrit, red cell distribution width, and platelets and mean platelet volume. For the blood chemistry, we register 30 different parameters: glucose, the lipid panel, which includes total cholesterol, LDL, HDL, VLDL, and triglycerides. Also kidney function markers, creatinine, blood uric nitrogen, uric acid, bilirubins, the liver function through LDH, AST, ALT, GGT, and also the results of C-reactive protein and serum electrolytes. For the body composition markers, we use the results of an electrical bioimpedance, and this allowed us to see not only the weight and height of our patients, not only the body mass index, but also the fat mass, the visceral adipose tissue, the percentage of muscle mass, the lean body mass, hydration, and face angle, which is a parameter of the cellular integrity. And again, the tick-plex was done only in the SIP group. So with these variables, we have a whole picture of our patients. The analysis were statistical comparisons were performed using test chi-square or t-test and significance set at p lower than 0.05. We also had logistic and linear regression models for association between selected variables. Okay, so moving to the results. From these 692, 57% of the sample belonged to the SIP group, 43% in the control group. From them, 68% were female. That counts around 469 patients. This geographic distribution is regarding only the SIP group, and as you can see, we receive and attend patients from Australia, Romania, UK, Mexico, USA, and Canada. And as you can see, the majority of our patients came from USA and Canada, specifically from these states, from US and Canada. Regarding the age, the average of this population was 46 years with a median of 48 years and a range between 12 to 84 years. Okay, so these regards with their demographic information. Regarding the symptoms, in this table, I share with you and present to you the frequency of clinical symptoms from all the population. As you can see, fatigue is the most common chronic symptom. present in more than 75% of the sample, followed by arthralgia, cognitive decline, myalgia, history of psychological trauma or active psychological trauma. And one of the advantages of working in this multidisciplinary group is that together with the psychologist, all the medical team had the hypothesis that maybe the SIP group will have a higher prevalence of these two clinical symptoms. We also had the frequency of headache, previous antibiotic treatment, history of COVID-19, flu-like symptoms, fever, and erythema migrans, that it was present only in 6.2% of all the population. So if we divided and compare our study groups, we can see in this graph that fatigue was by far the most distinguishing symptom between the SIP group and the control group, with an odds ratio nearly to 14 times higher to present this symptom. Also, prior antibiotics and cognitive decline, erythema migrans, even though it has a very wide interval confidence, but it was associated with the SIP group, as well as fever, myalgia, and arthralgia. Interestingly, flu-like symptoms, there is no acute symptoms at the moment of the registration of these symptoms, and history of trauma or active psychological trauma was not associated with the SIP group. History of COVID-19 was inversely associated with the SIP group. With this, we suggest, because of the 68% of the female sample, we also perform adjusted odds ratio, adjusting for age and gender, because we thought that maybe those can be confounder variables. But again, as you can see at the bottom of the graph, fatigue remains as a distinguished symptom with an odds ratio nearly to 12. And also prior antibiotic use and erythema migrans were one of the most symptoms associated with the SIP group. But as you can see, cognitive decline and headache as a neurological symptoms, arthralgia and myalgia and fever as these systemic symptoms. So with all these results, we can summarize that fatigue, antibiotics, erythema migrans, but mostly cognitive decline and headache that are usually seen in chronic diseases can distinguish these two different study groups. Okay, so now moving to the laboratory results. I know that this slide is a little bit busy, but in this I present to you the bivariate comparison of blood count parameters between the SIP and the control group. And as you can see, I bold or highlighted those parameters that were statistically significant. Maybe we cannot see this clinically different between the SIP and the control group, but maybe our patients, if we see every individual, we can see values that are in the lower limit or the upper limit, but it's because it's not abnormal, we cannot appreciate these differences. So the mean differences between the control and the SIP group were presented in the monocytes, which the control group tends to be higher, red blood cells, hemoglobin, and hematocrit, and also the red cell distribution width and the mean platelet volume. As you can see, the white blood cells and the neutrophils, their p-value was nearly 0.5, but not significant. However, when we adjust for age and gender, this is something very interesting, because now when we compare the SIP group versus the control group, adjusting for age and sex, now we can see that white blood cells and monocytes count are actually statistically lower in the SIP group. The basophils are higher, hemoglobin and hematocrit as well, and the red cell distribution width tends to be lower. So for the following parameters, the blood chemistry and also the nutritional markers, I will present just these adjusted models for age and gender. So regarding the blood chemistry, after doing the adjustment for age and sex, we can see that potassium, urea, blood, urea, nitrogen, creatinine, and uric acid had this tendency of being lower in the CYP group, as well as liver enzyme AST, alkaline phosphatase, and GGT. In the case of the bilirubin, there was a mixed association, but the C-reactive protein was not different, neither the lipid profile in these two different groups. In terms of the nutritional markers or the anthropometric variables, these are the adjusted model for age and gender, and we observed two parameters that were different between the groups. The skeletal muscle mass tends to be higher in the CYP group, as well as the face angle degree. So taking all this together and sorry, just before that, remember that the tick-borne plus was done only in the CYP group, and actually we have the results from 367 patients. So here I present the reactivity to multiple tick-borne pathogens in the CYP group. As expected, the most common were BV, Borrelia burgdorferi, and their persistent forms, both in the IgM and the IgG. In the IgM, we can see that followed these VV and persistent forms, we can see Babesia, the most frequent, and then Bartonella. But interestingly, in the IgG results, we've seen that instead of Bartonella, there appears EBV. Of course, these results need deeper analysis in order to see all these polymicrobial exposure in this CYP group. So taking all these results together, we can summarize in this. We have seen that the clinical profile of the CYP group is characterized by fatigue, the history of EM, and use of antibiotics, and the symptoms like cognitive decline, headache, fever, arthralgia, and myalgia. If we use the serological patterns, we can see that this tendency of a decreased white blood cells and monocytes, an increase in basophils and hemoglobin and hematocrit, and also a decrease in red cell distribution in the blood chemistry, lower levels of potassium, urea, blood uric nitrogen, creatinine, uric acid, AST, GGT, alkaline phosphatase, and the total and indirect bilirubin. Just the direct bilirubin tends to be higher. Nutritionally speaking, they present high skeletal muscle mass and high face angle degrees, and we can see that there is a polymicrobial exposure in this CYP group. So imagine like doing this for every variable for each group, and then it will take a lot of time. So what will happen if we can use the information from patients, taking their background, all their symptoms, these lab tests, but also these trends, and have a prediction model? So this is what I'm gonna try to explain with you of this prediction model that we performed together with Kunal and Tio and an amazing team for having this machine learning model in order to predict the participation into the CYP program. So to determine which are the features that will oriented into going through a CYP group or going to the control group. So these had three different phases. The exploratory data analysis, second, the feature engineering and feature selection, and lastly, the model performance. For this, we had a subset of this database that was built by 50 patients for the Lyme or the CYP group and 72 patients for the control group. From these 122 patients, 70% of the sample was used for training the model, and the 30% was used for testing the model. So the first stage, the exploratory data analysis, these statistical methods help us to understand data better. And in this graph, I present to you the Pearson correlation with the target variable of Lyme. In the right side of this graph, you can see that symptoms are like the most positive correlation with the target variables to enter into the Lyme program. And H, chloride, glucose, and LDH are the ones that had this negative correlation with the target variable Lyme. So another form to visualize these variables is this heat map where we can place all the variables. And those variables with this yellow color had a strong or a positive correlation with the target variable, which is the Lyme or the SIP group. And those in the purple has this negative association or correlation with the not being in the Lyme group. Again, the symptoms are the most yellowish or orange variables in this all these data. So with all these together, we've moved to the next stage, which is feature engineering and feature selection. We see that the number of symptoms in patients was different between groups. In the Lyme or the SIP group, there were a tendency of higher number of symptoms in all the sample. And when we add the age to this analysis, we can see that the higher the number of symptoms, the younger the patients. So taking these into account, we performed that to all the variables that were analyzed and selected these 9 features, which are the percentage of lymphocytes compared to in orange is the SIP group, and in blue you can see the control group compared to the symptom count. So these 9 features were the percentage of lymphocytes, the percentage of monocytes, the red cell distribution with the platelets, glucose, AST, GGT, iron, and chloride. And with these 9 features, then we tested if these can predict the participation into the SIP group. And in these slides, we shared with you the model performance. In panel A, we can see the confusion matrix to detect actually the true positives and true negatives from the train set, but also the test set. In panel B and C are the rough curves and the precision recall curves. The nearest to the one, it's like having this perfect prediction, but we can see that they are quite distant or near one. Of course, the train set is higher, and then for the test set, we have like decent performance of the model with these 9 features. Okay, so as a conclusion, chronic tick-borne infections and non-infectious conditions can be clinically differentiated through patterns of symptom presentation. And the use of AI is fundamental to analyze retrospective data for enhancing clinical testing algorithms and diagnostic outcomes, with potential applications in optimizing chronic infections diagnosis and advancing the integration of clinical and biomedical information for prospective clinical decision-making. The clinical impact on patients' benefit is that chronic tick-borne infections are often underdiagnosed and frequently misattributed to degenerative processes. Clinically, these findings support a broader use of multiplex pathogen testing in patients presented with unexplained fatigue and neurocognitive symptoms or chronic pain, an approach that can lead to more accurate diagnosis and personalized treatment plans. Additionally, digital innovation models that leverage retrospective biomedical data hold promise for optimizing the diagnosis of chronic tick-borne infections and supporting prospective clinical decision-making. So thank you very much for your attention. Just before moving to the Q&A section, I just want to thank you, this amazing organizing committee, as well as the Sanoviv team that support this, and dear friends and colleagues, Flor, Astrid, and also Pippi and Dr. Sophie, that thanks to them, the TICPLEX has become now a reality in-house in our facility. So thank you very much, and I am open for questions.
Mitzu, nice presentation. Why not also look at tick-borne plus in your control group, to make sure that there is a difference in past infection exposure?
Yes, that's an excellent question because this is observational study and retrospective. We are just recording what had been done. So it will be ideal to have it as part of their programs, and I hopefully think that this will become a reality. But for terms of the analysis of this database, we couldn't have. But of course, that will be an excellent observation to compare these both groups.
Thank you. So I think there's time for one more question. Maybe I can ask one. Thank you, Mitzu. Really great visualizations. Could you talk about the comparison between the SIP and the non-SIP groups? Because the SIP group is a little homogeneous, whereas the non-SIP group is probably from different programs. So how do you see this comparison being maybe fair?
Yes, that's an excellent observation because the control group or the non-SIP group has patients that we have a lot of heterogeneity, and this is one of the limitations of this study because there are patients that has even only high blood pressure, for example, even though it's controlled, but they enter into the analysis, and it's not fair to compare. But we also have patients suffering from autoimmune or neurological disorders, neurodegenerative diseases, and also patients with cancer in stable situations. For this is an inclusion criterion, not for the study, but for entering to Sanofi to be stable. So overall, even though there are more symptomatic or less symptomatic, all patients need to be stable, not in a need of urgency. So I will develop and analyze, describe better the control group so we can have an idea of the different diseases that patients in the control group have, so we can have a better and more accurate comparison about the disease that were present for these analysis.
Great. Thank you, Mitsu.
Thank you.